afternoon, everyone. My name is Amy Swarzeski, and I work with the Medical Society of Virginia Foundation. I would like to introduce Dr. Margaret Cadre, who will be speaking on the chronic care management model, the integrated team model that has been developed by the Virginia Department of Health. I would now like to introduce Dr. Cadre.
Thank you very much, Amy. I appreciate it. Can I have the first slide, please? So we will begin by defining chronic care management because it is a very specific definition in terms of what the Centers for Medicare and Medicaid will accept and in healthcare in general. So chronic care management refers to the strategies used to manage chronic diseases in a comprehensive manner. And we also have a specific definition of chronic diseases. And the CDC defines that as one or more years of a condition that requires ongoing medical care or limits daily activities or both. In other words, you have a chronic disease that is requiring ongoing medical care as well as limits your daily activities. But if you, let's say you had a stroke, for example, you may not necessarily need excessive ongoing care, but you will definitely, in most instances, have some limitation of your daily activities. So that alone can be a criterion. CMS defines CCM as services provided by clinical staff directed by a physician or advanced practitioner, which occurs on a calendar monthly basis and which meet very specific criteria. The patient has to have 2 or more conditions expected to last at least 12 months, so until the death of the patient. The chronic condition must place the patient at significant risk of death or acute exacerbation. A comprehensive care plan has to be established on a monthly basis, which is then implemented, revised, monitored. And it is expected that the billing practitioner will spend upwards of 15 minutes on this particular care plan. The various levels of CCM are further based on designated CPT or HCPCS codes according to Medicare. Next slide, please. So most people do, most practices who do CCM tend to do basic CCM, which is at least 20 minutes of staff time with criteria, as I mentioned previously. Since the basic CCM code was introduced in 2014, several additional codes that allow for a longer period of time and so higher reimbursement have been introduced. And this is CPT 99491. The main requirement for this code is that at least 30 minutes of the time needs to be provided personally by the physician or advanced practitioner. And all the other required elements is with the basic. CPT 99487 is complex chronic care management services. And this allows people who may have 5, 6 problems that you're dealing with at least 60 minutes of clinical staff time, again, under the physician or AP care. And of course, there has to be evidence that the patient does have moderate or highly complex medical conditions that require significant work. Next slide, please. And the basic differences between the codes, just to emphasize it, is basically the amount of staff time provided and the complexity of care. The coding, and I bring this up because this is something that I want to draw your attention to. If you're in a standard ambulatory care clinic, you can use all of the codes that I mentioned. However, if you're a federally qualified healthcare center or a rural healthcare center, because you paid under the prospective payment system, you can only use one code, no matter how complex the decision-making or how much time you spend on the patient. And you need to be aware of this in terms of the potential reimbursement for the service. Next slide, please. And this is just a slide showing you the current reimbursement rates depending on the codes. And this changes on a regular basis, so you need to keep up with it. But it gives you an idea of the potential amount of money you can make. Next slide, please. Now, while the term chronic care management tends to imply care of the older patients, I do want you to be aware that really chronic disease exists across all age groups. 60% of adults in the United States have at least one chronic medical problem, and incredibly, 40% of children have also at least one chronic condition. And with the increase in morbidity due to obesity and so forth, we can anticipate that chronic diseases are going to be to present an even higher, account for a higher percentage of disease in the population. So saying all of that to say that when we think of chronic disease, it actually is not just related to older patients, and in fact crosses all spectrum. So we should be thinking from birth to death. So one of the problems we have with CCM, where it's confined to older patients, is that we don't have a payment reimbursement method yet. This is something that's currently being worked on. So we're certainly looking at CCM models to address the high maternal child morbidity mortality rate. And we're currently gathering data to show the value of having such a model in across the whole spectrum of age. Next slide, please. Just briefly to give you an idea of the problem we're dealing with, CCM as a mechanism to enhance care of chronic disease was introduced in 1996. Incredibly, 26 years later, although it's been repeatedly demonstrated to be an effective model for the management of chronic diseases, the US healthcare system is still struggling with its successful implementation and sustainability. And the major barriers really include the absence of a provider-led integrated clinical team, as well as having adequate financial support. Next slide, please. So as a result of funding from CDC, VDH has been able to look at models of care, chronic care, that will be a benefit for our patient population now and in the future. So VDH took advantage of the opportunity of collaborating with Johnson Health Center and FQHC located in Lynchburg, Virginia, to see whether we could develop a successful CCM model that will address the barriers, which as I mentioned before, one of the major barriers is the financial support. So we, as part of a collaborative, we developed an evaluation in 2022, the objectives of which were to determine if an interdisciplinary CCM team consisting of a provider, care manager, pharmacist, and community health worker can improve outcomes in patients with chronic disease while reducing provider workload. And the second objective was to determine whether reimbursement using the current Medicare CCM CPT codes would suffice to cover the added costs of the pharmacist and CHW. The collaborating organizations were Johnson, Virginia Department of Health, Connection RX, a pharmacy group, Virginia Pharmacy Association, and Health Quality Innovators, who were responsible primarily for the statistical analysis. And as I mentioned earlier, this project was funded through CDC a cooperative agreement with the Virginia Department of Health. Next slide, please. So the synopsis of the VDH-CCM protocol, it was a 4-month intervention. I mentioned what the primary outcomes were, and basically patients with diabetes and an A1C greater than 7, being able to show a decrease by at least 0.5% in the A1C, and the proportion of patients who achieved a final blood pressure reading of 140/90, less than 140/90. 621 Medicare patients with both type 2 diabetes and hypertension were identified from GHC's database, and those with uncontrolled disease extracted. This left us with a group of 256 patients who met criteria using this CCM eligible list and incident to the provider. The CHW did patient outreach, provided education about the CCM program, obtained agreements from consenting patients, and carried out entry and exit social determinants of health assessments. At the entry to the study and also at the end, CCM patients obtained a hemoglobin A1C, lipid profile, comprehensive metabolic profile, urine albumin, as well as pharmacist medication reviews. Next slide, please. And basically, the model showed great success in improving A1C levels, even though this was just over a 4-month period of time. 41% of people in the cohort showed significant decreases in their A1C levels versus just 12% in the control group. The uncontrolled hypertension cohort, we had 29 patients in that group. And again, we showed very significant results because the initial blood pressure, systolic blood pressure readings of the cohort were 155.8. And by the end of the study, the average was 138.8. And with regards to the diastolic pressure, the mean starting was 86.4 and decreased to 77.8. And this was, the p-value for this was 0.001. So this was highly significant. So you can see that we did demonstrate that both diabetes and high blood pressure could be managed very effectively using this model. 71 of the patients that we recruited had a full medication review, and of those, 57 patients had 366 potential adverse drug reactions, which means that potentially these patients could have landed in the ER or even in hospital if the adverse drug reactions hadn't been captured. So that was really phenomenal. It also demonstrated that there was a 90% adherence rate. And claims that were submitted, we had a Medicare reimbursement rate of 85.5%, which is really quite extraordinary. Next slide, please. So one may ask why, for integrated team construct, we chose the CCM service. And this is because this is a service that's 100% reimbursable for Medicare patients. So that allowed us to have a really good control of the finances. It is, of course, performed by a clinical team. The standard team tends to consist of just the provider and care manager, leading to underutilization of this service. And we realized that in order to improve the effectiveness and make it more practical, we really needed to get a healthcare worker who could do high touch, which is the CHW, and you could also benefit from the technical support of a pharmacist. Next slide, please. So the integrated team construct as developed by VDH, it consists of a provider, care manager, community health worker, and pharmacist. And these are the minima. If you happen to be at an organization where you have more resources and you wanted to add, some additional people, such as a dietitian and so forth, you can. But this is the very minimal construct that can achieve our goal, which is to improve health outcomes, find a way of paying for the service and taking the pressure off the provider to carry out the work that's needed to support the program. Next slide, please. So in terms of the financial model, providers are salaried, so they're paid regardless of whether CCM is happening or not, and CCM is one of their responsibilities. Care managers are also salaried, and of course, CCM care is part of their job. So the only providers on that team, members of that team, that needed financial support that was not already there were the pharmacists and the CHW. Now, pharmacists are salaried, but may not have comprehensive medication reviews as part of their responsibilities. So we really do need extra dollars to support their input into the patient's care. CHWs devoted to CSM is definitely an added budget item. It's not a standard in most clinics or hospitals even. And with this new model, the CHW salary can be fully supported. And I will demonstrate that a little bit later. So successful CCM increases the financial bandwidth of the organization through direct reimbursement. And most insurers would give extra monies to organizations called merit dollars if they have very good outcomes for certain diseases. So there's additional potential money that can be received by the organization in this fashion. Next slide, please. As I mentioned before, the reimbursement rate was 85.5%. This means for every claim that was sent in, on the average, we got back 85.5% of what was billed. And based on this, CHW, who has a monthly case load of at least 100 patients, has the potential to bring in greater than 82,000 annually. And of course, is improving the outcomes as well. In Virginia, the average CHW salary is around $50,000. So that the money that's left over from the 82,000 will cover more than 450 hours of pharmacist time. So this really works very well. Next slide, please. The VDH integrated model is designed so that it can be incorporated into any primary care setting. And that's very important because one of the other obvious barriers to implementation in the past, in spite of its being a successful model, is that if you just place it into a clinic without appropriate regard to the clinic, whether the clinic is really prepared to manage the patients according to the CCM way, you're not going to have any level of success. It will flounder pretty quickly. With the VDH model, we build the model into the system rather than expect the system to adapt to the model. Minimal staff required, a physician or advanced practitioner and a nurse. We can use innovative methods to complete the rest of the team. So in the case of the pharmacist, there are many ways if the clinic does not have its own pharmacy to incorporate a pharmacist consultant. And the consultant can come from a private organization that does consults, or it can come from pharmacies with which the clinic does business and who will be prepared to give some hours of their pharmacy time to the clinic. Of course, they're going to get reimbursed through the whatever is brought back in to the clinic through successful claims. In the case of the CHW, if the clinic does not already have a CHW, VDH is willing to give a small grant initially to support one. The long-term financial plan being for that clinic to be able to ultimately support the CHW fully from Medicare reimbursement received through CCM. Next slide, please. In terms of helping clinics in Virginia to integrate the CCM model, VDH will assess the readiness of that clinic through a formal, for CCM, through a formal survey. We will meet with clinic leaders to determine feasibility of initiating the CCM program. We will educate staff and assist staff in developing appropriate workflows based on their resources. We will also assist staff in developing templates appropriate for progress notes. We will also assist staff in creating templates and workflows that are central to accurate billing. And we will appoint a contact person for further help or questions. And we will also monitor the progress of the CCM services implementation and the progress with the aid of clinic staff. We are here to help you develop a successful model because we know how important CCM is going to be in the future for sure, and how important it is right now as we speak, because CCM is a very high dollar, chronic diseases, I should say, is a very high dollar healthcare cost. And we absolutely need to address it in as many ways as possible. Next slide, please. There are basic steps in executing the model. You do have to have a practitioner champion because this is not the type of program that can run passively in the background. Somebody has to be driving it, making sure that patients are identified with the disease process of concern, making sure that patients are stratified according to risk factors for adverse outcomes, so that we can identify the patients at highest risk and who obviously would be high priority for outreach. The champion also oversees what's going on with the workflows and making sure that the patients are properly tracked all the way through, because when you enroll a patient, that's not the end of the story. That's really the beginning of the work, truly. You've got to do what is necessary to keep the patient in the program and make sure they're doing well. Next slide, please. In terms of success, there's certain key factors that weigh heavily with regards to whether you're going to be successful. Timely and correct billing codes are an essential to successful reimbursement. And this involves tracking the status of claims and making sure that claims are being reimbursed in a timely fashion. Patient outreach is central. And so we do have to look at whether patients have telephones, whether they have restricted services, because this is a real part of life for many of our patients. They may have a phone, but the phone may be restricted in terms of text messages and other such things. Also, since a lot of this care can be done by audiovisual means, broadband issues can become a bit of a problem. Although in the state of Virginia, at the governmental level, there's active work to address the broadband issues. And another outreach challenge is the time of day that the patient is called. Many patients, even though technically past 65, still work during the daytime, and therefore attempts to reach them during the day may be unsuccessful. So have to look at, make sure there's flexibility with regards to call times. And patients should also be encouraged to register for the portal access, because that really enhances the fluency of communication. Next slide, please. Practices who adopt a CCM model of care need to ensure that a mechanism is in place for proper note-taking, because Medicare has very, very specific requirements in terms of the content of the note. So really it is best that a template be created so that there are less opportunities for errors in the quality of the note-taking. And ideally, the CCM note should just be one note, although we have 4 parties involved in the care of the patient. It's still better to keep one note. So that makes it easier for the provider when he or she goes to take a look at the note and review it. It also makes it easier for someone who's auditing, your CCM notes. If it's all in one, the main note is all in one place. So the 4 people who are actively participating on the team should enter, a few notes there. They can always refer back to, say, the prepare, which can exist as a smart form. The CHW can always refer back to the prepare in their remarks, but they can say basically the prepare was, unremarkable, and anyone can go back and look at the prepare. CCM is relatively new to most providers, so they're often not familiar with the coding. So training is needed, or templates should be developed with the pertinent cues and pre-populated codes so that the provider doesn't have to spend a lot of energy on that part of the note and can focus on the care of the patient. Improper coding is a hazard in terms of reimbursement. So it's very important that emphasis be paid on that. And as I mentioned before, there needs to be good. Someone specifically needs to monitor and track claims, because it's very easy for claims to fall off the map, if you speak, so to speak. Next slide, please. And we have a team, which is a collaborative team with BDH members and members from the Medical Society of Virginia. And we have Dr. Margaret Kadri, who's the clinical specialist, Patrick Wiggins, who is the head of the program, and Amy Swizeski, who is leading the effort at MSV, the Medical Society of Virginia, as well as Mary Beth McIntyre. These numbers listed here are the contact numbers. And of course, when we work with a specific organization, there may be additional ways that will be available to contact us. If you have any further questions about this program after seeing this video, please reach out to us. We wish to help you get it started and maintained. Thank you so much for your attention. Appreciate all your work.